Okay, so we'll get started. So steroid-induced hyperglycemia. So this study is really wanting to understand providers' attitudes and knowledge concerning steroid-induced hyperglycemia. Just a short description, steroids have frequently been used in chronic conditions such as pain, autoimmune disease, malignancy, or post-transplant. They have also been used increasingly for management of hypoxia in COVID pneumonia, as Decadron has been associated with decreased mortality. One of the most common side effects of supraphysiologic dosing of steroids is hyperglycemia. Hyperglycemia can occur in those with or without diabetes. To date, there are no randomized clinical trials demonstrating the best management of steroid-induced hyperglycemia. The use of insulin in such patients is often recommended as it allows for dosing adjustments. Providers' ability to manage such patients has not been well studied. At our institution, we have devised an insulin dosing algorithm for persons with diabetes who are receiving Decadron. Despite this, providers still request endocrinology consultation. As a result, we would like to conduct semi-structured interviews with inpatient medicine hospitalists to better understand their attitudes and knowledge of the name of steroid-induced hyperglycemia. So I'm going to ask you a few questions. What is your full name?
Alex Maknovich.
And what is your profession? Would it be NP, PA, or MD?
MD.
And are you at LIJ or North Shore?
North Shore.
And what are your years of practice?
10 years.
Okay. And how do you identify your race?
White.
And do you identify as Hispanic or Latino?
No.
And what is your age?
42.
And what is your gender?
Male.
Okay. So I'm gonna jump along to the diabetes care questions. Just making sure. Okay. So how long have you been managing persons with diabetes in the hospital?
I'm sorry, how long?
Yes.
I mean, my whole career, so probably 10 years.
Okay. And how comfortable do you feel taking care of persons with diabetes?
It depends on, it depends on multiple things. The acuity of the illness that the patient's coming in for, steroid use, if they're post-surgical or not.
Okay. And what are some of the challenges? You've kind of spoken to this, but what are some of the challenges in managing persons with diabetes?
Exactly those things. If they're on steroids, if they're post-surgery, if they have an acute illness occurring, if they are intermittently kept without food during the hospitalization.
Okay, thank you so much for sharing. So next I'll ask you a few questions about steroid dosing. How often do you manage patients on high doses of steroids? Would you say daily, weekly, monthly, or less than monthly?
I would say monthly.
Okay. And how comfortable do you feel in prescribing steroids?
I would say somewhat comfortable.
Okay. And how comfortable are you in tapering steroids off?
Very comfortable.
Okay. And what does the term physiologic dosing of steroids mean to you?
I'm sorry, you say physiologic dosing?
Yes.
That mimics the body's natural production of cortisol.
Okay. And when and why would you start a patient on stress dose steroids?
if they have suppressed adrenal function.
And how would you taper down stress dose hydrocortisone?
Based on the resolution of the acute illness for which it was started and or surgery. And then once that has resolved, and then then it depends on how long the patient was on the stress dose steroids.
Mm-hmm.
So if it's less than 14 days, I would taper it off. I would taper every 2 days until they're back to their maintenance steroid dose.
Okay, thank you. And then if a patient was chronically on prednisone 5 milligram and required stress dose hydrocortisone,
Yes.
how would you taper them to prednisone 5 milligram?
Same way. Resolution of the reason for the stress dose steroids, and then every 2 days until we get to the 5 milligrams.
Okay.
I guess I would decrease. Well, if stress dose is 100 Q8, then I may go to. I would have to do calculations. So I don't have a specific percentage that I go by.
Okay. The following questions are about steroid use during COVID-19. Did you manage patients with COVID pneumonia during the first surge of COVID-19?
Yes.
And during that time, do you recall using steroid therapy?
Yes.
If so, which steroids did you use?
Did you say during the first wave?
Yes.
During the first wave, Solumedrol.
Okay. During the second surge, Decadron was added to the algorithm for managing persons with COVID, pneumonia, and hypoxia. Did you manage any patients like this?
Yes.
And what percentage of these patients developed hyperglycemia? Would you say 0%, 1 to 25%, 25 to 50%, or over 50%?
I would say 25 to 50%.
Okay, and how comfortable do you feel in the insulin management of persons with diabetes and Decadron use?
Not comfortable.
And how do you manage steroid-induced hyperglycemia?
I temporarily raise the insulin dose based on the sugar level, and then based on whether they're eating or not, and based on whether they're overweight or underweight, and then also based on a 24-hour insulin requirement.
Okay. If you had a 60-year-old, 100-kilogram patient with normal renal function who was insulin naive with well-controlled diabetes starting on Decadron 6 milligram, what would you prescribe for them?
Did you say a patient had well-controlled diabetes?
Yes.
And they're obese?
They're 100 kilograms.
100? You said 100 kilograms?
Yes.
And then we were starting, I would do a sliding scale for the first 24 hours.
Okay.
And I'm sorry, you said 6 milligrams
yes.
of Decadron, right?
Yes.
Okay.
Okay. And what if the patient was 80 years?
Same.
Okay. And what if the patient was on dialysis?
Same.
Okay. And are you familiar with the insulin algorithm for persons with diabetes receiving Decadron during COVID-19 management?
No.
Okay. So I'm going to show you the algorithm. Actually, Shante is going to share her screen to show you the algorithm.
Okay.
So you can go ahead and look through it slowly, and you can let Shante know when she can advance down the screen.
Great. Insulin naive, Atlantis daily, give 0.2 per day. Okay. You can go down. Great. Okay. Great. Okay. Yep, got it.
Okay, great. On a scale of 1 to 10, with 1 being the least helpful and 10 being the most helpful, how would you rate this algorithm?
10.
And what would help to make the algorithm better?
Can I see it one more time?
Mhm.
Is there anything there about whether the patient is eating or not? I didn't see that. Ensure patient is on a consistent diet without evening snack. Okay, so then order blood glucose. So I would say if they had a section about what to do if the patient is eating much less than they would at home.
Okay, thank you. That's really helpful. And when managing these patients, when would you call an endocrine consult?
Well, with the protocol, I wouldn't call an endocrine consult.
Okay, great. So that actually wraps up the questions we had. Thank you for your time. I'm going to stop recording.